Welcome to the Dr. Payne Show. Yeah, we're going to cover all kinds of stuff on the show today. As always, your phone calls 416-870-6400 star 640 on cell. The lines are wide open. You have concerns about your health, your pain, stuff like that. That's what we talk about here every week, and we love to field all your phone calls and take them over the next hour. I just learned that you are deathly afraid of rats. This is a conversation we had. What's wrong with you?
I'm just incredibly afraid. I was telling you that I watched that documentary this morning on Netflix, and it's ruined my whole morning.
So you have no rats going around your clinic? Have you ever checked the cafeteria?
They were like showing rats coming out of the toilet and everything, and I'm now I don't even want to go to a toilet.
Can I tell you something? I had pet rats when I grew up. I've had 5 or 6. I was young.
You went down in my books, John.
Dude, they're fantastic. They're great animals. They're clean. They're polite. They're, what? They are clean. Domestic rats are incredibly clean compared to hamsters.
Oh, God.
What a pain.
Anyways.
Here, look.
Anyways.
Week that was. That's how we always start, Rat Boy. What's going on?
I can't think of anything else. Week that was. Yeah. Over the last few weeks, we've dealt a lot with speaking about whether it's been numbness and tingling or any neurological symptom in the hands, the feet, et cetera, et cetera. And I've given a few clinical cases where the root cause of that numbness or tingling or that neurological symptom has been due to something other than what was thought by that person or that person's healthcare professional. Last week after the show, I had an email from John in Oshawa who brought up the fact that he was having numbness and tingling for a long time and was getting checked out often and was just kind of being misdiagnosed. And finally, it ends up being diagnosed as multiple sclerosis. And so he just wanted to bring to my attention that numbness and tingling can often be something more serious. And I absolutely agree with that. And we've talked about this on the show, but I did think it was an important point to highlight and something that I always say. Anytime you have a symptom or a sign, the key to the treatment is getting to the right diagnosis. And it is true that sometimes numbness and tingling in the hands, the feet, wherever, can be due to some type of neurodegenerative disease, such as a multiple sclerosis or an ALS, et cetera, et cetera. So that is something that anytime you have neurological symptoms needs to be considered in what we would call the differential diagnoses, which are essentially a list of things that could be causing those signs or symptoms. Now, more often than not, obviously, that numbness tingling is going to be related to something more benign, right? Because those things aren't as common, but that doesn't mean that it's not possible that it could be something like that. And that's where having the right healthcare professional you'll be able to figure those things out. And what's interesting about neurological symptoms is most people think that in order to determine whether something is just more of a benign neurological symptom like a disc herniation or whether it's something more serious like a neurodegenerative disease such as MS, that you need advanced imaging. A lot of the times, the simple tests that we can do in our office, that neurologist or that I can do in my office, screening at reflexes, motor strength, sensory limits of the person's perception, and also looking at something called upper motor neuron lesions. These are all tests that can be done in the office that can really point us whether something is more serious versus more benign. So it doesn't always require waiting for that MRI, and that's one of the big things that I try to get across with people when they call me for the consultation. Come on into the office. Let me go through a detailed history, because listening and doing simple physical tests is something that's quickly being forgotten in our healthcare system. If you talk to a lot of older physicians, they'll tell you that the newer generations of physicians and doctors are a little too reliant on special testing. And it takes away from what we call clinical acumen, which is the ability to hear and see a clinical presentation and start to have an idea of what's going on. So anyways, I wanted to highlight the point that you don't always need the big, bulky MRI machine, and it may be part of it, but you can get an answer just by good history and good physical exam. And then if we feel that the MRI or some other type of special imaging or other test is going to be absolutely necessary because we suspect something, then that's really what those tests are there for.
I think it's interesting too, but the counter to that would be these old guys and old doctors, the young guys like yourself. They understand that there's a lot more physicality with people nowadays. I mean, people are doing more stuff physical out. I mean, everyone's doing CrossFit, everyone's doing all these different things, and that probably comes with its own set of injuries and problems, which they probably would have no clue outside of going to a gym back in the day. You know what I mean? It's a changing landscape for sure. So you guys, there's a lot of stuff you guys know now that
for
other generations didn't know.
But I do think from a prudent standpoint, I mean, I don't see a patient that comes in and says, my shoulder hurts, and the first thing I do is send them for an ultrasound or an x-ray. What's important is get a history, do a physical exam. If you can understand it without going to those tests, then all you're doing is saving a couple things. When you think about x-rays, there's exposure to radiation for the patient. So you always have to, anytime you're using a modality that's going to have radiation like an x-ray or a CAT scan, you're going to have to weigh the benefits versus the risks for the patient. Is it going to give me more information and I'm just exposing this person to potentially radiation? And also the other thing is the cost on our healthcare system. All those tests that we do cost money. And if it's not absolutely necessary, if you look at the budget for healthcare and how much money is wasted on unnecessary tests, it's a lot of money. That money equates into what we pay in taxes. So, our responsibility in having good clinicians who use their clinical acumen before just jumping to a test is very, very important because it helps to save money for us too.
There's also that aspect of waiting for the MRI, which is nice in this country. You can do stuff a lot in your clinic. I can't for the 3 months I'm waiting for an MRI.
Exactly. And that's what that's another conversation that I have with people. Just because you're waiting on an MRI or waiting for a test, and unfortunately, you're right, there are long wait times. That doesn't mean you can't be doing anything in the meantime, because if I have sent people for imaging because I suspect it's a disc herniation or something like that. But that doesn't mean I say, well, let's not treat it till we get that MRI, because all you're going to do is potentially make it worse.
How many times have we heard that? That's pretty smart. Even I've heard doctors say that, just wait till we get this back. And there's nothing going on in between.
No, and I think, again, this needs to look at, if someone comes into my office, and I think I gave this clinical example about a month ago where a lady had come in and she had fallen while raking leaves, and I looked at her shoulder and it looked like the shoulder was out of place. I didn't have to do a physical exam because I was able to see it. I sent her for an x-ray right away because I knew what I would likely see and I needed that x-ray to confirm it. So that's not always the case, but sometimes you have to understand something like an MRI, which takes a much longer period of time. Do you really want to be waiting a month, 2 months with no intervention until you have a result? That may not be the best thing for your prognosis. And what I always say is imaging and special testing should be done to improve someone's prognosis. So even when I'm confident with someone that they have a disc herniation and they say, well, I think I want an MRI, I basically say, well, what added information is it going to provide? It's not going to change the treatment. We know that it's likely what it is. But, it's important to consider all things.
Phone lines are open. Would love to hear from you this afternoon. Bring it on. Dr. Lou is here ready to answer your questions. 416-870-6400, star 640 on cell. Reminder as well, free consultations. Drop by the clinic or clinics, whichever one he points you to, and you want to send an email. It's info@paincarecanada.com. Just getting warmed up. The Dr. Payne Show. It's Talk Radio, AM 640. 1214, open lines, 416-870-6400, star 640 on cell. Bring your concerns. Let's hear them till 1 o'clock this afternoon. Right, answer your questions. Dr. Lou will be until 1 o'clock. By the way, 1-855-55 Dr. Lou. You want to book an appointment, have a consultation, or info@paincarecanada.com. Dr. Luigi Nally, doctor here for the hour on the Dr. Payne Show. Back problems, always lower back.
Yeah, lower
constantly in pain.
Yeah, lower back, neck problems. We've gone through this before. Obviously, the more prevalent areas of the spine to have issues, mainly because the middle back, the thoracic spine, has the rib cage, which provides an inherent amount of stability, versus if you were to look at a skeleton or the human body and you look at the low back and the neck, the only thing that actually keeps it upright is the muscles. Otherwise, there's nothing else. There's no architectural stability there, like the thoracic spine, because of the rib cage. And so because of that, that obviously means that those areas are going to be more predisposed to problems. The lower back is more common than the neck because gravity, right? Even if you would look at the anatomy of a spine, the vertebrae and the discs get bigger as you move towards the bottom because it has to take on more weight. And we tend to use in our society, I mean, when we're picking things up, doing things, we're always bending at the hips, twisting, and those are things that are very, very dangerous for the low back. It puts stress on the disc specifically, and the disc, the outer layer can tend to rip, and then the inner layer, which is very similar to a jelly, which is the annulus pulposa, can come out, and that's where disc bulges, disc herniations. Now, inherently, those things are not pain generating themselves. What happens is when those bulges put pressure, because what does the spine do? It provides a structural stability, but it also encases our spinal cord and the nerves. So once pressure is put on those structures, that's where pain starts. So that's the problem with the low back and and the neck, but definitely those are very, very common areas. The neck too, right? Especially with how much of our population works at a desk. That we see tons of this. People with
heads bent over looking at phones all day, right?
Yeah, phones. That's a big thing too. Now that's become more prevalent because now we're texting. Once upon a time, it was that we had the phone on our shoulder, and so necks were getting kinked that way. Now we find, and that you used to see a little bit more where we would say it was unilateral, where the problem was on one side. Now we tend to see that the problem's on both sides because you're holding a phone looking down in front of you.
And your head's pretty heavy. With that, you wouldn't realize how much your head weighs without those neck muscles.
I remember
right?
learning, and I don't want to get it wrong, but I think it's something around 10 pounds. Right?
That's a lot to carry around on top of your shoulders all day.
So, definitely it adds up for sure.
I got, is it Luis or Louis here? Hello.
How you doing, sir?
Hey, how are you?
I'm good.
What's your concern?
I have emphysema. I was diagnosed about 3 years ago.
Yep.
The doctors call it severe emphysema. I'm 47. I was talking to my specialist, my chest specialist, last week, and talked to my doctor, and we talked about a transplant.
Okay.
The fact that I'm still young and all that.
Mm-hmm.
I still smoke. I'm a 32-year smoker. I still smoke 2 or 3 cigarettes a day.
Mm-hmm.
And the specialist tells me that it might not be the best option due to complications that comes afterwards, and it won't increase my life expansion to more than 5 years.
Right. That's with the transplant.
Yes.
Okay. So what is your question then?
Is it a good idea? Is it a bad idea? Is it really like I talked to some people, I search online, and apparently the medication and the lifestyle that you have after the surgery, it's really complicated.
Yeah, so... Yeah, and let me comment. I'm not a respirologist and I don't do lung transplants, but I can tell you that, number one, you said that you have this and you're still smoking. I would probably say that, maybe cutting out the smoking is at this point is probably a good idea.
Yes.
And then, actually, I can relate to this on a personal level because my mom actually has COPD. She was a smoker. And one of the things that you're looking at is essentially lung function. So how much function of the lung do you have? And I'm sure your doctors let you breathe out into a computer machine that tells you how much lung capacity you have and what kind of volume you have. And there's... Sorry?
When I was diagnosed, he said that I lost 80% of my lung capacity already.
Right. So then that means you're functioning on like half of one lung. So, in the absence of most of the medications that are available, like the corticosteroids and things like that to help your lung function, if those things aren't helping, then I would assume that the only thing left, the only option would be something like a lung transplant. But I would definitely say that if the people that you're dealing with, your respirologist and the specialist, are suggesting that, again, I've always said this for everything. This is the conversation. I can't answer your question because I believe that you have to have this conversation with those people that are recommending that and just understand the risk versus benefit ratio, right? If someone's going to tell you, well, this is going to prolong your life 10 years, well, the other option may be that you may be dead in a year or 2 years, right? Mm-hmm. So I'm not really sure, and I don't know your specific case, but I encourage all people where surgery is an option. Most people that are recommending surgery are recommending it because they feel that it's going to be some type of benefit versus not doing the surgery, and that's the way we work in healthcare. We make a recommendation based on believing that the benefit is greater than the risk. So I definitely think that that's a conversation that you continue to have with your specialist. And, again, I would say that probably the cigarettes contributed to you having that, and maybe it might be time to say goodbye to them and see if that helps a little bit.
Queenie, hang on. We'll get to you in just a couple minutes here. Everyone else, give us a call, 416-870-6400. Star 640 on your cell. Dr. Payne Show, Talk Radio, AM 640. Get your free consultation happening as well. Don't hesitate. Go to see Dr. Lou. It's Queenie here. Hi, Queenie. Thanks for hanging in. How are you?
I'm okay. How are you?
Okay. What's your concern?
Well, I have numbness in my heel.
Okay.
And I'm wondering, like I had surgery, a hip surgery, and I've had physio.
Okay.
And it's still there. This numbness is there in the morning.
Okay, so wait, let's start at which heel is it?
My left heel. It's the heel, the leg that I had
the surgery on for the hip.
Surgery on, yeah.
Okay, did the numbness start after the surgery?
I think so.
Okay. And how long ago was the surgery?
The surgery was in July.
July. Okay. So have you have made the therapist and the surgeon aware of that numbness in the heel?
Yeah, now I'm going for surgery and for physio.
Okay.
And she seems to be sending me somewhere else. And she said maybe I would have to go to a neurosurgeon for some other more examinations or whatever for this numbness, because it could be related. But the first physio said that was a different subject. But the second physiotherapist said it could be related.
Yeah, I mean, I guess I could agree a little bit with both. It might be a separate issue. It might be related. Definitely the timeline suggests that it might be more related because it started after the surgery. You know, when they do replace a hip, they're moving a lot of structures out of the way. And in doing so, some things tense, maybe something gets a little bit stretched, and it could end up causing some issues, right? The other thing is once you have your body, see, the thing is with any type of intervention, whether it's a hip replacement, a knee replacement, or something like putting an orthotic in a shoe or whatever, anytime you have, your body gets used to your body being a certain way. So now all of a sudden you have a new hip, that hip's healthier, it can do things. Sometimes that increased mobility that you didn't once have can predispose you to other issues, just because, again, your body's not used to it. The best thing that I could say is it might be worth us doing a specific assessment because, again, it's very hard for me to say specifically over the phone whether it's related to it, not related to it. This is where, this is kind of the idea of the free consultation is I have a discussion like I am here with you, and I determine, this is absolutely something that I can assess and give you an accurate answer, and then we move on to the assessment. And, the other thing I want you, Queenie, to know and our listeners is we usually can do these assessments within a few days of you calling. So I try to keep my schedule open for just assessments, just so that there's no long wait periods for people so that they're getting the right answer.
Right.
And it's a $45 charge. And I mean, some people will look at that, and I think some people sometimes have a problem with paying for healthcare. But if we're not going to pay for our healthcare, what are we going to pay for? And, it's $45. There's so many more things that cost much more than that. And it's a comprehensive exam where we're going to get to the bottom of something, and you're going to get advice. And my advice is basically going to be what could potentially make the difference in getting something better. So I would encourage you, give us a call. This is absolutely something that we can assess, get to the bottom of it, and give you the right recommendations on what to do.
Okay, I would like that very much, because I think this is divine, because I just put the radio on and it's really what I'm looking for. Like, I want an answer. Yeah,
so if you just leave your number with our call screener, I'll even give you a call later on in the week.
Queenie, again, just on your end, 1-855-55 Dr. Lou would be that number. We'll get to Randy. Hey, pal.
Hi, how you doing today?
Good, sir. What's going on with you?
Well, I was diagnosed with Crohn's disease about 10 years ago. At first, my flares didn't happen as much. Okay. But now my flares are happening like constantly. Like I'm saying, once every 3 months. I've been in and out on many treatments, but other things happen during my flares now that didn't happen before. Like I get sores, I get like constant pain and the numbness too.
Okay.
And they just keep saying, just keep doing the treatment. It's not going to get better. It always just stays about the same, or it gets worse. Try to relieve stress.
Right.
But I was wondering if there is any other things that I could do, because it's becoming more bothersome.
Right.
Like, don't get me wrong, the pain hurts, but it's more bothersome now than anything else.
Sure. What type of treatments have you had? Has it just been strictly like more conventional Western medicine approaches to this?
No, I had Remicade treatments, Imuran. And it stopped. There was a medication called Semzia. I was on that for about 4 years. But
you've never tried any more, I guess, integrative alternative approaches?
No, I haven't.
Okay, so some things, so let me touch on this. One of the things that we also have at the clinic is our integrated approach to healthcare, where we work with naturopaths, acupuncturists, et cetera, for especially things like this, pain related to visceral issues. Now, one thing that I want to touch on, Randy, that this is not just for you, but for all our listeners. The sympathetic and the parasympathetic nervous system, we've all kind of heard of it at some point or another. The sympathetic nervous system is that fight or flight where, it's our way of defending against ourselves. And the parasympathetic system is what keeps us calm and allows our body to do what it has to do. the neurological innervation to the GI system is incredible. It's where most of the innervation happens in the whole body. And one of the big things with most GI issues that has a very big contributing factor is the stress levels, because stress is going to affect that parasympathetic. Again, your body, your bowels are going to work well when you're in a good parasympathetic state, right? Because that makes sense. If a tiger was coming after us, we wouldn't be worrying about going to the washroom. We would probably, our sympathetic system would allow us to defecate quickly and move and run.
Out of there.
But when your parasympathetic system is acting well, that's when you have good sleep, you have good bowel habits, good bladder habits. And so a big thing, part of the treatment, again, with this, and this is where the integrated approach to healthcare that we try to go with, is working on the conventional side, which are things that you've already done with the medications, working with some alternative therapies like the naturopathic medicine and the acupuncture, the traditional Chinese acupuncture, but also implementing social workers and psychologists to work with the stress levels because of how important it is in something like this with Crohn's disease. So yeah, Randy, I would absolutely say, again, similar to our last caller, this is something that I can definitely make an appropriate referral to the right people for you. And so you can leave your number or give us a call at 1-855-55-Dr. Lou. And for our listeners, it's DRLOU. And so, yeah, give us a call and we can definitely try to get you in touch with some, trying to an all-integrated approach to that problem.
416-870-6400, star 640 on cell. Got open lines. You got some time. Give us a call. We'd love to answer your questions. Get some solutions happening. Springboard that from this show or the remainder of the half hour here. The Dr. Payne Show, Talk Radio, AM 640. It is 12:30. Got some open lines. 416-870-6400, star 640 on cell. It's funny. You mentioned that talking about the GI, the gastrointestinal stuff, and it's true. I mean, I had issues 15 years ago with that. And after having every physical examination from, sigmoidoscopies to everything, there's nothing physical I can find. I said to myself, you know what? This is completely stress. It's mental. And I worked myself out of it. My own personal CBT, cognitive behavioral therapy, and that does so much, right?
Yeah, and one of the things when you look at GI issues, there are some things in the GI that are obviously not always related to stress, right? But once you start getting to things like a lot of people come in and say, I've been diagnosed with irritable bowel syndrome. Irritable bowel syndrome is, again, in healthcare, what we would call a wastebasket term. It's similar to something like fibromyalgia.
Or sciatica.
It's essentially what happens when you rule out any serious cause. It's kind of like irritable bowel syndrome. That's, you have an issue with your bowels. We can't say that it's a tumor or that it's this or that it's that. So we say it's irritable bowel. It's the same as fibromyalgia. You have pain. We can't really find, a specific fracture, a tear, something like that, but you have widespread pain. We call it fibromyalgia. These things are often related, not often, always have a psychological component. And it's so important for patients to understand that when I say psychological, people are always like, are you saying we're crazy? No. Stress is a real thing. It affects everybody. It's just the reality of the world that we live in. Our mind is connected to our body. And so the things that happen in our mind can affect our body and vice versa. That is just the reality. And people should not be so apprehensive to understand that the way you think, the things going on in your life can affect your physical body. It is just the reality of what happens with the human body.
How many times have you stood, on the sidelines of a wedding table, knowing that you have to give the next speech? You're like, I would love to go use the washroom right now. I don't get it because I do this for a living, but a lot of people are terrified of that thing.
Public speaking.
And that's it.
Yeah, for sure. It's just the reality. We can all do that. I've always said, you could be, have the worst flu in the world. And if you all of a sudden are watching the TV and you see that you won the lottery, you won $50 million, I guarantee you that cold's going to feel better really quick, right? Because of how powerful the mind is going to be.
Yeah. 416-870-6400, star 640 on cell. Sally, good afternoon.
Good afternoon.
How you doing?
I'm good. I have a question. I've had some neuralgia, paresthetica in my left thigh.
Yep.
Since September.
Okay.
I'm 5 feet tall, 110 pounds. I'm not the traditional person who has that. I'm very active. I play hockey a couple of times a week, and I'm a RMT, so I have a lot of physical work.
Yep.
So part of my question is I've had lots of treatment, massage, chiropractic, acupuncture.
Sure.
I stretch all the time. And it's better. It's getting better.
Yep.
But I still have this. And I'm just kind of wondering what I have done differently. I've been an RMT for 20 years. I'm very active skating. I haven't done anything really different.
Sure.
The only thing that's different for me is in July of the same year, I had a colonoscopy for the first time. I'm 50 years old. My sister died of cancer last year.
Sorry to hear that.
I'm wondering, thank you. I'm wondering is there any relation to the colonoscopy that could have irritated that lateral nerve, or that's my first question.
Sure.
And then the other one is, do you have anything else for me to do?
Yeah. So just for people listening, meralgia paresthetica is like, what meralgia paresthetica is on the lateral, which means on the outside part of the thigh, a numbness and tingling. So it's very similar. It's a very similar term to sciatica. So, and we've talked about this a lot, where that's just describing a sign. That's not necessarily a diagnosis as to what's causing the meralgia paresthetica. Meralgia paresthetica could be caused by a couple of things. It could be some type of a tight muscle, like we've talked about, which impinges on the lateral cutaneous nerve, which is a branch of the femoral nerve, which innervates the skin in that area. And so that could cause numbness and tingling. It could be a disc herniation higher up around T12, L1, L2, because that's the nerve that makes up for that area of it's a little less common, again, because it's closer to the thoracic spine. It's not as further down. But Sally, I would say the biggest thing when I deal with things like this is, and I'm sure you can appreciate this being an RMT, that it is really something that I should probably assess and take a look at, because there's, a handful of things that could cause it. Your question about could the colonoscopy have caused it? The pudendal nerve, which kind of innervates all the the genital area, is in close relation to the femoral nerve. I mean, I can't say for sure, and it doesn't sound likely. I would definitely say that based on what you're doing, you've said you haven't changed a lot, but the one thing that you said that was interesting was you've been doing it for 20 years. The reality about the body is wear and tear is a real thing, right? So it could just be a matter of wear and tear. It could be a matter of posture things. When I look at things like this, I try to also look at it from a functional perspective, where I'll get you to actually, one of the things that I do with physical capacity evaluations and physical demands analysis is you identify what the person needs to do in their day-to-day life, and then you can look for the way that they're doing it and see if there's a way that you're doing it that's maybe putting pressure. But I think it would be great, and also from an interprofessional perspective, I'd love to have the opportunity to do an assessment with you and try to get to the bottom of it.
Perfect.
Okay.
Yeah, I've purchased a hydraulic table so that I'm not so flexed forward.
Sure.
I've done. Yeah, that would be great.
Awesome.
Where are you? Where is
our main clinic is in Etobicoke, where I actually work out of to do the assessments.
Perfect. I'm in Port Credit.
Awesome.
Perfect.
So the number 1-855-55-DRLOU.
Get to Ram here before the break. Hey, Ram, how are you?
I'm doing pretty good. Yourself?
All right. What's your concern?
Yeah, my concern is I've got burning in my in both feet, and I've got lower back trouble most of my life. I've had herniated disc, and I had surgery on the herniated disc back probably about 16, 17 years ago.
Okay.
So I'm getting this burning sensation in my feet, and at night it wakes me up. In the middle of the night, it probably gets so hot that I have to go and put my feet under cold water.
Ram, do you know when you said they did back surgery, what did they do exactly?
A discotomy.
Okay. Yeah. So one of the things that happens, and what was common practice once upon a time, and it's still done sometimes today, but not as often, is where they'll remove the disc and fuse the vertebrae. Yeah. Now, we've kind of talked about this. If you look at, let's just deal with the low back. More often than not, there's 5 vertebrae. Sometimes people have an anomaly. You can have 6, but there's 5. If you were to fuse 2 of those together, let's pick you fuse L4 and 5 together. Mm-hmm. What has to happen is all those joints work together to allow a certain amount of movement. You're not going to move any less. So what has to happen when a segment doesn't move, more movement has to happen in other areas. There's compensation that happens. So what ends up happening a lot of the times after some surgery like that, where there's a fusion component, is that other areas take on a new burden of stress. And when there's new burden of stress on bones, Wolff's Law, which is a law that dictates that as bones have more pressure on them, they lay down more bone. That's what arthritis is. So you start to get degenerative changes. So Ram, it sounds like like you probably have a component of stenosis, which is where either the central canal with the spinal cord or the peripheral canals of the IVF where the nerves come out have either become encroached on by that extra bone, and it's causing those types of symptoms. But again, I can't say for sure, obviously, over the phone. Come in, we can do a proper assessment. We can figure out if that's exactly what you're suffering from. And if it is, then we can give you the right recommendations as to what you do for stenosis.
Ran, for that contact, 1-855-55 Dr. Lou, DRLOU, or info@paincarecanada.com. You want to call in this afternoon, you got till 1 o'clock, 416-870-6400, star 640 on cell. Back to your calls in but a moment here on the Dr. Payne Show, Talk Radio, AM 640. 12:45, lots of phone calls to get through. We'll get to them. Ian, good afternoon.
Oh, hi.
How are you?
I'm doing well, thanks.
What's going on with you?
I'm 50 now, but back when I was 40, I was diagnosed with Horner syndrome.
Okay.
I've gone through all the tests for a number of years, and they fixed the ptosis in my eye.
Yep.
By basically cutting the eyelid off and then sewing it back up.
Okay.
But since for the last 4 years, I've been going back and forth to the doctor because my eye that was initially had the ptosis is irritated all the time, constant pain, blurriness.
Okay.
And they've given me drops. They've done a lot of things, but it's starting to droop again. So.
Okay. Now let me ask you something. Why did they say the Horner syndrome was happening?
Because of the ptosis in the eye and my iris.
Yeah. So okay. Let's just for our listeners that are just to explain it. Horner syndrome is a bunch of three main symptoms, which is that a droopy eyelid on one side of the face, that same pupil will be decreased in size, and that there's lack of sweating on that affected side of the face. It usually is related to some type of a problem with the sympathetic chain in the neck, which is the nerve bundle in the neck that, again, we just went over, the sympathetic chain that affects fight or flight responses. Horner syndrome can happen due to a couple different things. Sometimes it could be due to things like a Pancoast tumor, which is a tumor in the lung at the apex of the lung, which is right at the top. So if you're sitting there and you kind of feel your clavicle and you feel there's an empty space in there, that's the apex of the lung, and Pancoast tumors can form in there, and they can have an effect on those sympathetic nerve bundles and cause Horner syndrome. The other thing where Horner syndrome, and I guess that's what you mean, Ian, where they check for things, they were checking for more serious causes like that, putting pressure. But one place where I see a lot of Horner syndrome is in whiplash. So when there's a severe whiplash in some type of an accident where your head gets whipped forward and back, those sympathetic chains are stretched, and it can cause Horner syndrome. So one thing to maybe consider if you've never done it so far is if you had some type of neck treatment to really focus on getting the neck healthy. And when I say neck treatment, I mean some type of passive intervention, but also very, very good rehabilitation of what's called the deep neck flexors might be able to improve those symptoms.
Oh, wow. Okay.
So, do you know your cause, Ian? Just ask.
At this stage, they're just calling it idiopathic.
Yeah. And so I've said this before. Idiopathic means that they just don't know. And one of my professors always used to say that the doctor's an idiot and the patient's pathetic, and that's how I've always remembered.
That's outstanding.
Idiopathic. But Ian, give me a call. I think it's very worthwhile to do an assessment, and I'd really like to see what I would look for in your case is what's called the endurance of your deep neck flexor muscles, and see if there's a weakness component there, and if there is, give you some very simple exercises that you can do, and hopefully that can help you.
Oh, that would be great.
Okay.
Ian, appreciate it, pal. 1-855-55 Dr. Lou is the number to get a hold of. Got Steve here, and hi, Steve.
Oh, hi. I have an issue with my cervical spine.
Okay.
I had a diagnosis of mild antrolisthesis.
Antrolisthesis, okay, yeah.
Of C4 and 5.
Okay.
And also a degenerative disc at C3, 4, 5, 6, 5, 6, and 7.
Okay.
I don't actually have pain, but what I do have is discomfort that starts to move in after about 7 hours or so.
7 hours and doing what?
Of working.
Of working, yeah. Yes. So, for sure, degenerative changes in the neck, again, can affect what it is. It affects the space between the disc. It can encroach on the holes where the nerve comes out. The anterolisthesis is when one vertebrae falls a little forward of the one below it. That's why it's anterolisthesis.
Oh, okay.
And so sometimes that can also affect the hole where the nerve is coming out because that hole is made up of the vertebrae above and below. Sure. And so sometimes there's encroachment from that type of pathology. Again, Steve, you're another very good example of, in order for me to give a very, very specific answer in order to what you should be doing to potentially get it better or at least be able to cope with it well, I'd have to see you, assess you. If you have x-rays already with you, that's another big thing. People who come in to see me and any of our listeners that do come, if you have your medical information, bring it in. It helps.
Yeah, big time.
It helps to put a picture together for me so that I can review everything that's there and give you the right recommendations.
Right. So do you foresee like a relief from the tension and the
again,
discomfort?
so that's plan of management and prognosis. So prognosis is how likely you are to get better. In order for me to really give a good estimation of prognosis, I really need to see it and assess it properly. I can't say for sure because I don't know what it's due to for sure. I'm just going based simply on what you're telling me now here over the radio, but it's not something that I can absolutely say, yep, that's causing it and that this is how likely it is to get better. So, the proper assessment is where I'll be able to give those specific answers.
Starts with that phone call, Steve, 1-855-55 Lou. Give him a call, make an appointment, get in there. Hang on the line, guys. We'll get to you. Everyone else, 416-870-6400, star 640 on cell. Back to your calls. Dr. Payne Show, Talk Radio AM 640. 12:54, lots of phone calls to get through. We'll get right to them so we have time. Jeannie, hello there.
Hi there. How are you today?
Good. What's going on with you?
Well, I'm so happy to hear. I listen to you every day, and I told the girl, tell the guy to give the phone number out a little bit slower for us older people.
Well, you navigated it properly because you're on with us now.
Yeah, I kept listening and listening. I thought, oh, my God, I'll get it. I know I'm going to get it.
I thought it was pretty catchy, though, 1-855-55 Lou. It's a lot of fives.
But what I did get was the 416-870-6400.
So you got
that's
that in
the
you.
640 number. Okay, yeah.
You guys are swift.
Okay, Jeannie, what can we do for you?
Well, anyway, why I am calling, and I do listen to this program every day, and I've heard about Dr. Lou, and now it's a Dr. Payne.
Okay,
Dr. Payne's new to me.
Yeah, that's me, Dr. Payne.
You're Dr. Payne.
I'm Dr. Payne.
Oh, he's a pain.
Nice to talk to you.
Sure.
Okay, getting to my husband. About 2008, he had a dancing problem with one leg. Danced all over the floor. It was a terrible thing.
He danced on one leg?
Yeah, just the right leg.
Okay.
And anyway, he went and seen about it and had an operation because he had stenosis.
Mm-hmm.
And so that was crunching the nerves, because I don't need to tell you.
Yeah.
You know all about it. And that was causing the problem. And he had the operation when we're thinking, okay, great. But he did wait. He put it off looking for alternative care. And they told him, we think you might have waited too long because it might have damaged the nerves.
Okay.
So anyway, to this day, he still has the pain in the bottom of his foot. Sometimes it's really bad, and the pain goes up over his rib cage on the right-hand side to right under his arm.
Okay.
Wow.
All the way down his leg.
Okay.
Just the one side.
Yeah. So, okay, Jeannie, again, similar to, it sounds like there's a lot there.
Yeah.
But, I encourage you, if you have time to bring your husband in for that assessment, that's when I can really get to the bottom of these things and give a specific answer, because it sounds like you want a specific answer to what's happening with your husband, but I can't give that right now because I don't know enough. But, thank you for your call. You have the number, the 1-855 number. Let's book that assessment. Let's take a look at him and let's get to the bottom of it for sure.
Again, Jeannie, one more time, 1-855-55 Dr. Lou, DRLOU. Hi, Kim. How are you?
Good. How are you?
Good. What's your concern?
My husband is 45 years old, and the last few months he's been complaining about every morning when he wakes up, his calves are in excruciating pain.
Okay.
And when he gets out of bed, it's hard for him to walk.
Is it both calves or one?
Both calves.
Is it kind of like those nocturnal cramps where it cramps up in the middle of the night, or not? Or is that not what he's experiencing?
More like a throbbing, sore calf.
A throb, and it's on both sides?
Both sides.
Yeah, so throbbing, do you know, like, has he described it in any other way?
No, he's never said any kind of cramps. He just said that, like, they just feel overworked, overtired, kind of heavy feeling.
Okay, is he very active, like a runner or anything like that?
Yeah, he does work out.
Okay.
He runs on the treadmill, plus he does some weightlifting.
Okay.
He does have an inactive thyroid.
Okay.
So I was kind of looking online, and I noticed that they said that it could be associated with that, like joint pain, but I don't know.
It's not really at the joint. So commonly with the calves, it's either going to be something related to kind of the cramping aspect, which is usually due to a deficiency in minerals, usually potassium and magnesium. So one thing that he could try in the interim is add a banana and some green vegetables to his diet every day, see if it improves on that end. The other thing it could be is a neurological component, right, where it could be like the way he's sleeping is maybe aggravating a certain muscle, or there's an underlying disc herniation or disc bulge that's formed, and that may be aggravating it and causing that type of throbbing, because that throbbing type of sensation can also be related to neurological type symptoms. But I would say that again, this is where the assessment's really going to help me get to the bottom of it for sure.
We are out of time for the hour. If you're calling through and waiting, please take this number down, 1-855-55 Dr. Lou, DRLOU. Please follow up with your question at that number or info@paincarecanada.com. Dr. Lou will get to you. Now the show is done for this week. We're turning next week here on the Dr. Payne Show, Talk Radio, AM 640.